CHASH diagnostic approach in suspected CTDs. Number 1. Stepwise evaluation. Whenever a patient walks in with vague complaints, like fatigue, joint pain, skin rashes, or unexplained fever, it's tempting to jump straight to blood tests. But connective tissue diseases don't work like that. They reveal themselves slowly, almost like a mystery novel. Think of a young woman who says, "Doctor, I get rashes after being in the sun. I often have painful mouth ulcers, and my joints feel stiff every morning." If we rush to order every test available, we'll only confuse ourselves and the patient. Instead, careful history comes first. Then comes examination. If we notice a butterfly-shaped rash on her cheeks, or fingers that turn white and blue in the cold, or subtle joint swelling without much redness, that's when the story begins to point towards lupus or another CTD. Step by step, like a detective, we connect each clue. Number 2, autoantibody profile and what it really means. This is often where the puzzle becomes clearer, but it's also where most mistakes happen. The most common test is ANA, the anti-nuclear antibody. Almost all lupus patients test positive, but here's the twist. Many healthy people test positive too. So, ANA is the door. It lets you into the house, but it doesn't tell you which room you're standing in. That's why specific antibodies matter. Double-stranded DNA, or dsDNA, is strongly linked to lupus nephritis. So if our young patient also has protein in her urine, a positive dsDNA raises a red flag for kidney involvement. Anti-Smith antibody is rare, but almost diagnostic of lupus. RNP antibody is a classic marker of mixed connective tissue disease, especially when someone shows features of lupus, scleroderma, and myositis all at once. SSA and SSB antibodies point to Sjogren's syndrome, but they also matter in lupus. Imagine a pregnant woman with SSA antibodies. Her baby may be at risk of congenital heart block. That's a clinical interpretation that can save lives. Scale 70 antibodies suggests diffuse systemic sclerosis, usually with lung fibrosis, while centromere antibodies suggests limited systemic sclerosis, CREST syndrome. The difference matters because limited disease moves slower, while diffuse can be aggressive. Anti-Jo1 antibody comes into play when muscle weakness is paired with lung disease, classic for polymyositis. And ribosomal P antibody may explain neuropsychiatric lupus, such as seizures or psychosis. The pitfall? Doctors ordering an entire autoantibody panel for vague symptoms. Reports come back with random positives that don't match the patient's story. The golden rule: always match antibodies to the clinical picture. Number 3, laboratory panels. Beyond antibodies, routine blood work is incredibly helpful. ESR and CRP are both markers of inflammation, but they behave differently in CTDs. In lupus, ESR is often high, while CRP may remain normal. If both ESR and CRP are very high, it usually means infection or another disease like rheumatoid arthritis. Complement levels, C3 and C4, are like a car's fuel gauge. In active lupus, especially nephritis, these levels drop because they're being consumed by immune complexes. If we see falling C3 and C4 with rising dsDNA, that's almost a flashing alarm. Lupus nephritis is active. This small detail can prevent a dangerous mistake, like giving steroids for what is actually an infection. Number 4, imaging. Sometimes CTDs quietly damage organs, and only imaging reveals the truth. High-resolution CT scan, or HRCT, is the gold standard for interstitial lung disease. A patient with scleroderma may only have a dry cough, but HRCT will show early lung fibrosis long before an X-ray does. MRI is extremely useful in myositis. Say a patient is weak and their CPK is high. Is it drug-induced muscle damage or real inflammation? MRI will light up inflamed muscle and guide us correctly. Echocardiography is crucial in scleroderma or lupus patients with breathlessness. It may pick up pulmonary hypertension or pericardial effusion. Both can be life-threatening if missed. Imaging isn't just about making a diagnosis. It's about setting a baseline. Without a baseline, we can't know if treatment is really helping. Number 5, histopathology. Finally, when doubt remains, biopsy is the last word. In lupus nephritis, kidney biopsy not only confirms the disease, it also tells us which class of nephritis is present. This matters because treatment changes depending on the class. Skin biopsies are equally important. For example, differentiating a lupus rash from dermatomyositis or from a drug reaction. And muscle biopsies confirm polymyositis or dermatomyositis when MRI isn't enough. while also ruling out mimics like muscular dystrophy. Histopathology is not just about proving the diagnosis, it's about tailoring treatment. Dr. Yogesh summarizes, the diagnostic approach to CTDs is like solving a mystery. Each clue, history, examination, antibodies, labs, imaging, biopsy, adds another piece to the puzzle. No single test can give the whole answer. The most important lesson? Never treat the lab report. Always treat the patient. The biggest pitfall is forgetting this simple truth. And the final practical tip, connect every finding with the clinical story. Think broadly, but interpret carefully. Because with CTDs, early and accurate diagnosis is what protects patients from irreversible organ damage and helps them live healthier lives.